Hello, everyone. Welcome. We would like to start by noting that this panel discussion and the discussion afterwards is being recorded. For the panel discussion, only the speakers will be recorded. When we move into the discussion afterwards, if you do not want to be included in the video, we invite you to shut your videos off. You should receive an invitation now to consent to video. Okay, welcome. My name is Catherine Lopez. I'm a nursing student from Vancouver Community College. I'm currently completing my population health practicum with Reach Community Health Center, and I have the pleasure of co-hosting this evening, along with board member and chair of Reach Outreach Committee, Bill Hood. So firstly, I would like to start by acknowledging that this event is being held on the unceded traditional territories of the Musqueam, Squamish, and Tsleil-Waututh Coast Salish peoples. We also recognize that the peoples who have been displaced from their home territories through slavery and indentured labor. Just as an overview for the evening, we'll start with a panel discussion, followed by opening the floor for further dialogue at the end. The panelists will be talking about global funding and how this approach to funding can support more responsiveness and a better access to health and social services in our communities. Our three panelists include Colleen Fuller, who is the president of the Reach Community Health Center, Nicole, LeMire, who is the executive director of the Reach, and Stacy, Ashton, executive director of Crisis Intervention and Suicide Prevention Center of BC. If folks have questions, please feel free to share in the chat box, and we will discuss these questions at the end of the panel presentations. And as mentioned, for those who have recently joined us, please note that we are recording both the panel presentations and the discussion afterwards. So if you do not want to be in the video, we invite you to shut your video off and to share your questions and comments in the chat box. So let's get started. Our first panelist is Colleen Fuller.
Hi, everybody. It's great to see so many people. I'm really pleased. I'm, as Catherine mentioned, I'm the president of the Reach Community Health Center, and I have been on the board for a number of years. I'm going to be talking about global funding, what it is and how it works, or at least giving sort of the broad strokes of how it works. Unfortunately, not in this province because we don't have global funding for community health centers, but other provinces do use this as a way to fund CHCs. Reach has been involved in a discussion about global funding for many years. We started thinking about it really, I would say probably about 2013, 2014, around that time. And excuse me. In 2016, we began meeting seriously with the Ministry of Health, with the Vancouver Coastal Health Authority, with the divisions of family practice. We initiated a number of meetings with people in our own community, organizations, to talk about global funding, what it would mean for us and for our community if we achieved that type of a funding method. And so we have been involved in this for a number of years now. I'm not going to talk about Reach this evening. I'm going to, as I said, talk mainly about global funding. And so what I'm going to do first is share my screen so I can do that. I hope this works. Share. Is that working? Yeah. Yay. Okay, so we, community health centers, I'm sure everybody knows, are not unique organizations, but they were created in Canada in the early 1970s because there was a lot of interest in bringing together or widening the scope, I would say, on primary care and primary health care. So a number of provinces began to express some interest in this model. And some of them moved forward with it. Some of them moved forward and then moved back. And so it was kind of an uneven development across the country. But so since the 70s, there has been an agreed upon definition of what actually is a community health center. And they're publicly funded, they're nonprofit, obviously, they're membership based, they have boards that represent the communities in which they are providing services. They're very focused on not just the health of individuals, but the health of communities. And so we might call that health promotion. They provide a wide array of services. They are using, especially in, I think in the last, particularly the last 5 years, they're really pioneering in a lot of ways the use of integrated team-based care. They work with other service providers in their communities, and some people in the 70s and 80s and 90s used to call them one-stop shopping. I hate that term, but in some ways it works because people are able to go to a CHC and obtain a really wide array of services. They are also globally funded, except in this province. And the funding is not just done in a non-scientific way, if you want to describe it that way. They're based on the needs of the population served. So that is a distinguishing characteristic. As I said, they provide such a broad array of services. About 56% of community health centers in Canada provide services that overlap with up to 10 sectors. So you can see all CHCs provide primary care. There's a really strong focus on health promotion, on social determinants of health, and so forth. They provide family support services, including things like childcare. There's one community health center in Ottawa that provides low-cost laundry services for their members and patients and clients. So they have a very broad lens on what it means to serve the health needs of the people, the population within their communities. You know, I think that BC has one of the best health ministers in the country, but we don't have global funding. And this is in spite of a lot of effort that we've made. We're members of the BC Association of Community Health Centers, and BCACH certainly has been engaged in a discussion with the province about global funding. As I said, we're one of the only provinces in the country that does not have global funding. If you look at Saskatchewan and Ontario, all of their community health centers receive 100% global funding, which doesn't mean that they don't receive other project funding, because they do, but their basic services are globally funded. I don't know why this is the case in BC that we don't have global funding. We only very recently had a policy to support the development of community health centers. So we're lagging behind the rest of the country. And in some ways, we're also lagging behind the United States in this regard. There's a lot of interest in the US right now in global funding for both hospitals and primary care. And so there are a number of pilot projects in several states that are being funded by the federal government in the US, and the pilot projects aren't completed yet, but so far the results look pretty promising. I want to talk about what it means if you have global funding. Several years ago, pre-COVID, obviously, my husband and I were in Ottawa, and we went to a community health center, a couple of community health centers there. We were able to see what global funding looks like. Now, most of our primary care and social service providers are funded through a contract system. So they're contracted, and they also they're contracted by the province to provide a set of services, and they're also funded through grants. So the contracting is a system, and there's a lot of different ways that groups are contracted. That you may negotiate the contract, the terms of the contract, and the scope of services that will be supplied through that contract. They're usually 1-year terms, the contracts. They place a very heavy administrative burden on the applicant, on the organization that's trying to get the contract. There are high risks, especially for nonprofits, because if they don't get a contract, they often, because they function close to the margins, if they don't get a contract, they will often go out of business altogether. Contracting is very, very inflexible compared to global funding. And I'll give you one example that describes the difference between global funding and contracting. If you have a contract, let's say you're given $100,000 to provide the flu vaccine to people. And so you've got the contract, you're supposed to provide the flu vaccine. But if COVID comes along, people need a COVID vaccine and not the flu vaccine. But because of the contract that you have with the funder, you can only provide the flu vaccine. So global funding is quite different. It provides a lot of flexibility to organizations to respond to emerging needs within the community and so forth and so on. From the point of view of the government, global funding has also several advantages, one of which is that it provides a fixed amount of money. So if you got the $100,000 to provide vaccines, and then COVID came along and you had to get a different type of vaccine, you could supply the COVID vaccine, but you would not get more than $100,000 to do it. So the government has some control over the expenditure. You're just given a contract and you can spend as much money as you want. There are checks and balances. When we were in Ottawa, we saw how this works in action, and it was really impressive. Ontario has 105 community health centers. They're all globally funded. That funding enables them a high degree of flexibility in terms of staffing and programming and so forth and so on. The average size, Ottawa has 6 community health centers, and that's where we were. The average size is about 175 to 270 staff. And of that, whether it's 175 or 270 staff, only about 4 to 5% of them are family doctors. And that might sound shockingly low, but people are accessing a whole array of services: nurse practitioners, counselors, mentors, educational mentors, rehab services, all of a really, really broad array of services. All of the staff are on salary in these community health centers, and they all practice in interdisciplinary teams. The other thing that I thought was really interesting in Ottawa was that the community health centers work very closely with what are called community resource centers, and the community resource centers provide social services. So over the years, the 6 CHCs formed a coalition of community health and resource centers in Ottawa, and they work very closely with their social service and education partners, actually, to coordinate and deliver services through this coalition, which enables them, I guess, to allocate where the people will go if they need a particular service. We think that that the community would benefit from global funding, and we're still quite determined that this is going to come about within our lifetimes, but it requires a lot of understanding in the community and mobilization in the community. So that, I hope, gives you some sort of overview of the difference between contracting, which is what REACH receives as contracts and grants, and other social service providers on the one hand, and global funding on the other hand. I'm going to turn it over to Nicole. She is going to talk about how this would work with REACH. Nicole.
Yes, thank you, Colleen. Always nice to hear about global funding like this. Let me start by thanking the Outreach Committee of the board and the Vancouver Community College for this event. I do truly appreciate. I'm Nicole LeMire. I'm the Executive Director of REACH Community Health Center. And good evening, everyone. Discussion about funding models associated to nonprofit organizations are extremely important because they impact on our productivity, our effectiveness, and also our ability to make decisions that are best for those we serve. So I will use REACH to illustrate what I am trying to say. I will first try briefly reference to our approach at REACH, and then I will explain how we are financed and mention a few struggles that arise due to our funding model. And finally, I will comment on how recent circumstances allowed us to adapt. So let me just share my screen. So I just, that was my introduction. That was simple. So, okay, REACH Community Health Center, and I'm assuming you all know Community Center, and it might be a bit of dry presentation. And if it's too dry, let me know, somehow wave or whatever, but try to, yeah, it's the type of thing that I like, but it's not everybody. So let's try for our vision. Our vision is a sustainable, healthy community. And it goes beyond urgent and primary care. And it goes also beyond the direct services we provide to patients and clients who come to our doors. We strive to support our entire community in every way that meets its need to promote a healthy community. And our mission statement is written here, and please take a few seconds to read over it, or to read it over. So we approach healthcare holistically through the lens of health equity and community engagement. We believe that a healthy community is much more than the absence of diseases by directly addressing the social determinants of health, such as homelessness, food insecurity, addictions, employment, etc. Whenever is possible and when desirable, our team members use a team-based care approach to provide a high-quality services that are culturally safe, trauma-informed, efficient, and timely. Our interprofessional teams are composed of physicians, nurse practitioners, nurses, allied health professionals, and other support staff, working together with shared goals, sorry, could be gold, but it's goals here. They bring together their expertise to generate an integrated plan for clients, patients, and even our community. So we're not different from what Colleen mentioned about a community health center, and actually we're doing exactly what a community center is striving to do. So let's see how we are financed. So let's look at this one. It's our sources of revenues. To the right, the light gray is financed by Vancouver Coastal, VCH, and it represents 50% of our funding. And currently we have 5 contracts with VCH, not 1, 5. One of them is a contract to pay the salary of our physician at the medical clinic. These physicians carry a panel and provide longitudinal care. We have also an amalgamated contract that includes allied and support staff to care for patients attached to our medical clinic. And we also have a contract through the primary care network to increase capacity and access to our medical clinic. You guess it, these 3 contracts finance most of our medical activities and represent 49% of the financing received from VCH. We also have a contract for our urgent and primary care center, representing 43% of the financing by Vancouver Coastal. And we have a small contract to partially cover costs related to our multicultural family center, representing 5%. So each of these contracts has its own condition regarding performance indicator, which are related to population served, access, capacity, quality of care, you name it. Each is negotiated separately every 1 or 2 years. For some contracts, we report quarterly on performance indicators, while financial reports are every 6 months. For UPCC, we provide different statistics at different frequency, daily, biweekly, and monthly. The second category of our revenue is, in the dark gray that you see here, is the contribution of REACH to our community health center. And it's about 42%. And it includes revenue generated by our pharmacy and our dental clinic. Our medical physicians also contribute to this, and every year they generously give a percentage of their salary to pay for additional services to support their practice. And a small amount come from donation, rental, and billings. Finally, the last category of revenue, it's all others revenue. It's in the yellow, and it represents 7.4% of our total revenue. For most part, revenues generated in this category are used to address the social determinants of health, health equity, and engagement. Revenues come from 14 different funders, each having its own requirement and reporting frequencies. For most of them, we need to apply yearly. Of course, we are grateful to the multiple funders and partners because we believe that services offered in this category are essential to the well-being of our patients, our clients, and our community. However, you can understand that having to report 14 different funders in addition to report to Vancouver Coastal is extremely resource intensive. Let's explore this a little bit differently and maybe talking a little bit about what Colleen talked about resource allocation. So we have here a 4 rectangle. The first one to the left, the blue rectangle, is our urgent and primary care center, and it provides this service serve about 12,000 unique patients per year in a team-based care setting, in which 67% of our staff are medical professionals and 7% are allied professionals. A large percentage of our clients coming to our UPCC, it's important to mention, are from different marginalized population and will not receive healthcare services otherwise. For example, 7% of our visits at the UPCC are from patients with precarious status and or patients without MSP coverage. Moving to the right, we're having the medical clinic in green rectangle, and it has a panel of 5,200 patients. That means that our team sees 5,200 patients per year, at least once. 63% of the staff are medical professionals, while 12% are allied care professionals. Many of our medical patients have complex medical and or social issues. For example, in the past 2 years, we accepted over 1,000 new patients, all of whom presented with major complex issues. Recently, we have also observed an increase in the number of patients from marginalized communities, probably due to COVID, because we actually put our energy to concentrate on these type of these population. So since then, we observed that we noted an increase in number of patients requiring more than 12 visits annually. We observe an increase in patients self-identifying as Indigenous, patients on opioid agonist therapy, patients with substance use issues or with mental health issues, people needing trans care. So you can see that we have people coming to our door. Like, the point is really that people are coming our door are complex patients for most part, not all, of course. And our pharmacy is in orange, and our pharmacy has over 8,000 clients. Many clients are from medical or UPCC, And in addition to providing consultation and dispensing medication to these clients, our pharmacists advise our providers on medication and prescribing. These roles take up a large part of their work because of the complex medical pharmaceutical issue of many of our patients. And finally, our dental, it's in dark blue and has about 3,200 patients. Many of them are on provincial dental insurance with very little support to address social determinant, with very little support. Many of them are on provincial dental insurance and are working poor without insurance. We do subsidize these people. So anybody can put themselves on silence? Thank you. So, so in total, we handle close to 75,000 visits per year to one of these 4 departments with very little support to address social determinants of health. As you can add, only 19% of medical and UPCC resources are allocated to allied care. So due to the number of and complexity of people coming through our doors, we often find our allied professional at UPCC and medical at over capacity, with wait time of several weeks to get the first appointment. Coupled with insufficient resources, this can be draining and difficult for staff. So in addition to our medical and UPCC allied professional, we have now a newly created healthcare support team that assists these patients and other marginalized groups in our community. As mentioned, funding for this team represents 7.4% of our yearly revenues and is coming from 14 different sources. Many of these funds are, however, new money injected by different funders to provide additional support to our communities to cope with the effect of the pandemic. Now, the pandemic has been quite challenging at REACH in many ways, but it has also had positive externality. And let's explore this. So many funders granted the latitude during the pandemic to pivot our services to support patients and community during this period. That allow us to be more responsive to our clients and patients and better support our community. So for example, we went in support with the resident of the tent city at Strathcona Park. You will remember at that time, people were camping or resident at that park. We were able to actually do a lot of flu vaccination because we believe that it was important for people to get vaccination due to COVID. We also did COVID vaccination clinic. We add additional counseling, additional social worker, and other support to medical patients during the pandemic. And we hosted community health bulletin calls for our local partners, so to update them regularly during the pandemic. Then we also were able to supplement our services offered through our medical family center. We got an extra grant to support people with mental health and substance use. And now we did lots of workshops, and we also do individual counseling. This will be effective until March 2023. We also add extra grants to support girls and women facing domestic violence and to educate on gender-based violence prevention, and a grant for anti-racism data legislation consultation. So, and then let me through one more. We also got an extra grant from the federal government, which allowed us to run our indigenous and public health programming for fiscal year 2019 to 2021. So we were able to deliver workshops for COVID and COVID vaccination to marginalized communities to inform. We were able to adapt workshop to indigenous population, indigenize our workshop. We were able to hosted blanketing ceremony for survivors of residence schools. You will remember there were a lot of activity around there. One of them was held at the West Coast night, attracted about 600 people, and was in partnership with Vancouver Native Housing Society. We also distributed foods, and we also distributed and warm clothes to people. So all this is actually to address the social determinants of health in our community and where the needs were. Currently, these two programs I just want to mention because I think it was important that BCACH, BC Association of CHC, is currently financing these two programs. Money will run at the end of August. So with these new resources of funding and additional staff, we recognized even more the importance of addressing the social determinants of health and engaging in our community. We also witnessed the impact of health inequity and observed so many vulnerable groups were disproportionately affected by the pandemic. We needed to reorganize our teams to deliver support services. And that was supported by most of our funders. In doing so, we created a cross-departmental allied team from medical, UPCC, and MFC. We also created an outreach team to ensure REACH attends important community provider meetings and outreach to vulnerable populations. So these actions allowed us to expand our existing multicultural family center and create a new department, which we call Health Equity and Engagement. Let's go very briefly through this, just so to give you an idea of how we pivoted our services to ensure that we address the social determinants of health. In the rectangle to the right is the team that I was talking about, the allied team: social workers, counselor, gender-based violence, basic for health coordinator, cross-cultural health promoter, indigenous health promoter, elders in residence, rec therapists. We also had consultants and contractors for workshop and specialized clinics. And we also teamed with other partners, for instance, the Canadian Mental Health Association, to provide support to people that need employment and with the different barrier to employment. And we're having, just to name a few, but all this is actually temporary, like it's something, and we want to continue to address these because we think it's important. So if you look at the circle here and you have like the logo REACH and you go a little bit the circle out, you see that all around it's the social determinants of health, starting with immigration, age, mental health, job insecurity, housing, food security, gender, indigenous, and different cultural languages. And the out circle is all the thing we did around this. With this, actually, we feel that we actually fulfill our mission, and that I mentioned about to approach health holistically. So I will finish by leaving you with a little bit the following. REACH has been actively and adequately responding to the need of its community with the help of our funder and partners. Tonight, we indicated that most of our funding is allocated to medical services, including urgent and primary care, dental and pharmacy services. Although we can serve many marginalized populations, very little money is allocated to adequately address social determinants of health, undermining perhaps the primary care services we deliver to these marginalized populations. We have also allocated sources of funding and argue that reporting to 19 different funders leads to far-reaching inefficiencies. Each funder has its own reporting format with different reporting periods and frequency. For most of these contracts, we must reapply every year or every 2 years. Besides, having so many short-term contracts made it difficult to plan for the future while provoking unnecessary uncertainty to our staff and our community. Also, these requests for funding and reporting take up a large part of our time, while we could utilize this time doing other work, such as spending more time, managing and directing the work of our staff, planning, organizing, evaluating, adjusting. We could also improve on the delivery of our services via quality assurance initiative. We could coordinate the work of different departments and improve on efficiency and service integration, and reduce the wait time to see our providers. We can consult and work directly with different communities and services providers to coordinate our work to better serve our needs, the needs of our clientele. We could develop new programs to continue meeting the needs of our communities. This is just to name a few activities that we could do instead. So at the same time, and I don't know, at the same time, we are and have been accountable to our community via an elected board of directors that meets every month. They too expect us to report on activities and data and financial data of our organization. We also report to our members and community every year with an annual report and an AGM. Wouldn't it be great to simply share these monthly and annual reports to only one funder? This may be the promise behind global funding. Thank you.
Thank you so much, Nicole. Next, I would like to introduce you to Stacy Ashton, who is Executive Director of Crisis Intervention and Suicide Prevention Center of BC. Sharon, feel free to introduce yourself.
So I'm Stacy Ashton. I'm the Executive Director of the Crisis Center of BC. I'm actually coming to you today from the unceded territory of the Kakite here in New Westminster. So just to get a sense of what we do, we run the crisis lines in the province. So we run a regional line for the Vancouver Coastal Health Area and 1-800-SUICIDE and 310-6789 mental health. So that's 3 crisis lines. We answer about 45,000 calls a year. And the real great thing about a crisis line is we're able to de-escalate crisis with people through collaborative conversation over the phone. And about 98% of our calls, we don't have to go beyond the phone. 2% of our calls, we have to call for active intervention because we might have a suicide in progress or an imminent risk of suicide. But for the most part, we're able to do things and support people just on the phone. So like REACH, our revenue is from all over the place. We have been around for 52 years, so we've got a really strong donations from longtime donors. We have a grant and foundation proposal pipeline where we probably write about 100, right away for about 100 plus grants and foundations and things like that every year, and get back what we can. And about 20% of our budget right now is with either the Vancouver Coastal Health Authority or the Provincial Health Authority. And we're in the process of changing owners. So we have been contracted through the Vancouver Coastal Health Authority for quite a few years. And this year, the Provincial Health Authority has decided to fund all of the crisis centers across BC. There's about there's one main one in each health authority, and to have all of that come under the umbrella of the province. We have the gaming grant, and we got that nice wage subsidy. We also sell workshops and training. So we've got a whole bunch of different ways that we make money. And that's pretty common in larger social services organizations. So there are different kinds of funding models in social services, similar to health services. The one that we have mostly been going by is line-by-line service contracts. So that's when government wants something from you, so they want to purchase services from you, like crisis line services, and they tell you how much they're going to cost. They're going to pay you, and they get you to line by line. How are you going to spend that money? So you have to do a lot of reporting, and you really have to make sure that you're spending the money the way they expect you to. So you don't get a lot of autonomy in how that money is spent. One of the amazing things with COVID funding was surge funding started to come in with much more flexible usability. And that's how we really began to see how this kind of a global funding model could really work, even in a crisis and an emergency kind of a nonprofit. What happened when that money came in is we were immediately able to look to, okay, we're seeing calls rise. So we need to increase our staff crisis line responders, and we need to have the supervisory framework and support to go with that, so that we don't end up just burning out our crisis line responders because we've put so much work on them without any support. We were able to offer hiring and retention bonuses, which is something that you would never think you'd be able to do in we have to account for every line by line. But that was completely necessary in the marketplace today, because we're seeing people have a lot of options about where they're going to work. So we weren't able to hire or retain our staff, and we needed to do something about that. With the increased crisis line responders, we were able to spend more time on follow-up with at-risk callers, and we were able to allow for Slack. So the key thing about Slack in crisis services is you can't be busy all the time, because if you're continually maxed out, when things get hotter, you can't respond. And we saw this being managed day after day with hospitalization usage and COVID. The goal was to keep it as about 80% occupancy in the hospitals, because if like that COVID rate ticked up, you needed to be able to get to 100%. Like you needed to have that Slack in case you needed it. Most service contracts don't like Slack. And so you'll see things in the crisis world like CAR 87, which is a police and mental health professional that go out together when there's a mental health crisis in the community. But it would only have been, it was a 24-hour CAR, and maybe it would be called out, 3 or 5 or 6 times a day. So, well, that didn't seem like enough usage. So what happens is, you start looking at how you can make that funding more efficient. So you begin scheduling in that CAR. But of course, when it's scheduled, it can't respond to emergencies. And at this point, the CAR 87 crisis response CAR has a 3-day waiting list. So it's no longer an emergency service. If you don't protect your Slack and your crisis services, you're not going to be able to offer on-demand emergency services. The flexible funding allowed us to engage in partnership building and collaborative impact initiatives, and we were able to streamline a lot of our accounting, human resources, and fundraising, because we got to choose what we were going to do with the money, and then what we wanted to do with the money was make us more efficient overall, which is something you keep getting called to do in government, but rarely are allowed to spend the money doing that. One of the things to think about when you're looking at how social services and health services in general work is for-profits, when demand rises, they get more customers, they get more money. So it's a good thing when demand rises. For us, when demand rises, like the number of people who call the crisis line increases, if we don't have that flexible funding, we can't grow with demand, which means we have to provide less service per person, which means that we don't get to answer all the calls, which means that we leave people at risk. that's kind of a key thing that you'll see, and I'm sure Nicole at Reach can say the same thing, is the link between people needing our services and benefiting from our services doesn't match the funding model that we have. That really seems to come into play when we're looking at the difference between health and social services. So what's beautiful about Reach, as an example, is you've got that blended health and social services. That means that instead of having to send everything that needs help over to the health or policing services, you can keep it within the social services. What we find is when you underfund social services, you end up over relying on your health and policing services. And that's just much more expensive. So another piece of this core funding and global funding idea, when you're allowed to flex your spending between social services and health services, it really allows you to use that money more effectively, because the more you can invest in the social services, the more you can avoid overusing those health and policing services. And the crisis lines are a great example of that. With every call we de-escalate, we prevent a police mental health response. And of our 45,000 calls, we've estimated that about 20,000 of them, if they'd gone straight to 911, would have required a police response. So already that's about $14 million that we're looking at in policing costs that we didn't have to spend because we spent a half an hour or 45 minutes or an hour on the line with that person instead. Probably the closest comparison to community health centers in like the crisis sector is the crisis care continuum idea. And it's a bit similar to how Foundry works with youth. So Foundry is like a collection of nonprofits that will all live in one place, and Foundry will put this place together and allow them all to work together. And Foundry is it's funded by government as a package, so that youth in a community are able to access mental health and physical health and education support and everything at once. If you do that with a crisis care continuum, you can have the same kind of an impact, where if you have crisis lines taking care of all the people who just say they need help, and then crisis lines figure out, well, how are we going to resolve that? Is this a mental health problem? Is this a social services problem? What happens through that process is you begin to use less and less of your policing and hospital and healthcare services. So it's that, again, that idea of investing in the front end, and ensuring that you're looking at the least intensive interventions that are actually needed in any given situation, rather than not funding flexibly these social services pieces, and then the only alternative is to go with more expensive pieces. So I think that's what I wanted to say about this. Yeah, thank you.
Thank you so much, Stacy. Colleen, can I turn over to you?
Yes, thanks. Great presentations, Nicole and Stacy. Really enjoyed it. I was just going to sort of sum up. It's obvious that both on the social services side and the healthcare side, there are really similar challenges, not just in terms of how much money organizations receive to provide services, but the way that money comes. You can see that both for Reach and for the the situation with the crisis lines that Stacy was describing, that there is an extraordinary burden, administrative burden on the organizations to apply for the funding, to report on how they use the funding that they were provided with. And of course, that they're not funded to do that administration. That's not as usually part of the contract. So these are extraordinary burdens. And because of this, as Stacy said, this false distinction, and Nicole really stressed this as well, the false distinction between healthcare, medical care, and all the other parts of our lives. It's a false distinction that these areas are interlinked within our communities, within our own homes and households, and how we intersect with both the social services side and the healthcare side. And yet there's kind of this wall between these two sides. And so if you underfund and underutilize one aspect of this circle, you are increasing the use of another part of the circle. In the case of the crisis centers, the use of police and healthcare, and within a community health center, if you are not keeping people healthy, they are using healthcare services more, both hospital and primary care. I also think that there's a lot of potential here for there's a lot of collaboration in both of these areas, both what Stacy was describing and what Nicole was describing. There's a potential for a really, really high level of collaboration across these two divides as they are now. And one of the things that supports that level of collaboration is a more flexible funding model. So we talk about this a lot at REACH. We talk about the lack of flexibility and the demands of our current funding model, but we're not alone in that. We know that our social service partners are confronting a lot of the same issues. And so hopefully going forward, this will be the basis of discussion in the future.
Thank you. Would like to now move into the question and statements section of the evening. And if you would like to share, I've sent out a little message to letting you know that you can either direct message me or put your hand up. I'll do my best to monitor. We're over 2 screens here now, over 25 people. The floor, Jane, I see you have a question. Jane Turner, go ahead.
Yeah, thanks, Bill. Actually, I wanted to first of all, thank you to the 3 presenters. They were excellent presentations, really enjoyable. And I wanted to go right back to something Colleen said almost at the first of her presentation. So I hope everybody remembers. Colleen, you were talking about the Ontario example, and you gave the statistics about how few doctors were actually involved in direct patient contact at CHCs that are globally funded. Did I get that right?
Yeah, about 4 to 5% in the Ottawa area anyway, of total staff.
Yeah, so I know that REACH has been working on and instituting a team-based care model. If we got global funding, would that allow us to better utilize our docs for the things that they needed to be utilized for, and make it easier for people to see a variety of care, that because the funding is no longer attached to the physician the way that it currently is? Or would that be a huge problem from the Doctors of BC contract? Like, could we do that? Could we just sort of open it up and say, here's our team, let's give them the money?
That's the idea, but I'm going to let Nicole answer that.
Well, actually, what I want to say is I do not think that the proportion of money allocated to primary care is high. What we want to have, like, I think we have the number of physicians and nurses that we need, and nurse practitioner to serve our community, the medical need. What we need is to have something to wrap around around these services. It's like, for instance, like right now, the 7%, like if I had 10% of that revenue to wrap around services, add on my contract that I already have, and having one contract. And then you have the flexibility. They don't tell you, okay, you have to put 10% of your patient will need to go to counseling, and 20% will need to go to social worker, and the physician will need to have 100% of these visits. So we need, it's more of a, like, once you have the money, then anyways, you understand? Do I make sense?
Yes, and I think what I heard you say, which is probably critically important, is it's not that we can take the money that we currently get in from our medical team and redistribute it. We need more to then be able to wrap around the service that the medical team provides currently.
Exactly.
Okay, thank you.
Thank you, Jane. We now have a question from Audrey. Audrey.
Hi, good evening, everyone. Thanks so much for our speakers. I'm Audrey Gay from the BC Health Coalition. I want to say how much I appreciate the vision of the organizers for the panel and bringing both the health services and the social services together. So hearing from both Nicole and Stacy really illustrates that this is a far-reaching issue that goes beyond health. So I really appreciate that conversation across sectors starting, and I guess my question is about how we can build on that. So I think, Colleen, you said while we were wrapping up that you know, if there was global funding, there would be capacity for that kind of cross-sectorial collaboration. But of course, we need that collaboration and those conversations to happen in order to get to global funding. So my question is about how you imagine that organizing to happen across health and social services. And Colleen and Stacy, you'll know that at the Health Coalition, we've had conversations about building on those conversations, and that's in early developments, but we really do see a need for health and social services to come together and advocate for better, more sustainable funding models across the sectors. So I'm just curious to hear, to have another opportunity to hear your thoughts, or if there's others who have ideas about that here tonight. I'd love to hear a bit.
Yeah, I think that's a big, that's a kind of an exciting challenge, I think, for us. I don't think it's a daunting challenge at all. I just think that there needs to be a lot of discussion about it. And I know that we've had these discussions at the BC Health Coalition. I represent REACH at the BC Health Coalition, so I know about the discussions, and that Stacy has been involved in those as well. I think that there are ideas from other provinces. I don't know what's going on in Manitoba, for example, or Saskatchewan, but in Ontario, there are actual coalitions bringing together community health centers and social service providers. And I think that education, there's participation from educators and so forth, because if you were talking about going upstream, for example, on mental health, you want to develop a relationship with educators in the public school system. So I thought that was that's a really good model for us to look at and maybe inquire about. And there have been, REACH has been doing some of this work over the past number of years. A lot of it got bombed out of the water because of COVID. And so our meetings with other organizations, came to a standstill until we learned how to use Zoom. And now we're all tired of Zoom. So, but other organizations are having exactly the same challenges that Nicole and Stacy were talking about tonight. And so we know that that's the case, and we should be creating a round table to have a conversation about how can we work together to change these funding models. And we're going to have to talk about more money, as Nicole said, as well. There's no doubt about that. But we also have to think about changing the model of funding so that we can collaborate more effectively with each other, that we can address social determinants within our communities, and ensure that people aren't having to, scrimp and save to go and see a physiotherapist, for example, this type of thing. So yeah, I think that there's a lot of potential to have conversations with other organizations.
Thank you, Colleen. Stacy, did you want to reply to this as well? There's another question after you do.
Yeah, I wanted to just give an example of a place where, one of the things we know as a crisis line is when there's a crisis, there's opportunity. And so one of the places that we were able to kind of get involved in was during the flooding, the health emergency management team for the provincial health authority. We found out through our various relationships that we have that that there was room for crisis lines to be doing some work, and not even doing work, but just be recognized for the work that we're already doing. So when all the floods happened, the crisis lines in the interior just started ringing because that's where people would naturally go to call. And we were able to connect in with the health emergency management folks and actually highlight that was already happening, with the idea of, this is happening anyway, but it does mean that it's a surge where we're having to scramble people that we don't have any way to pay for. But we're doing it because we want to answer the calls. So they were actually planning on, well, maybe we should make a completely different crisis line, just the flood line. So there's money available when there's these kinds of crises. And the money gets loosened and scrambled in a crisis. So if you have the ability to reflect on what you're actually doing when a crisis hits, and then connect with the folks at the health authorities who are going to be in charge of managing that, we found that that's really helpful in helping them understand what we can do for them. The other thing that we did with them was we provided suicide risk signs, so that the folks that we were referring callers to, the folks that are going to help you figure out your insurance and things like that if you'd lost your farm, knew what the suicide warning signs were, so that they could be more confident helping people or reacting or knowing what it means when somebody's yelling at you for no reason after they've just lost their farm, right? Things like that. So I think there are ways of just doing it. And if you can find a crisis and then reach out, that's where you're going to build some really strong relationships in a good bonding experience.
These are fabulous examples. I just want to remind everybody, we got about 20 minutes left. The current speakers list is Jiwei Lee is going to go next, then John Calvert, then Barbara Wood, then Daniel Cook. So I've got 4 people on the speakers list. So Jiwei, let's go to you. Thank you very much.
Thanks, Bill. My name is Jiwei. I'm a family physician at REACH and also a public health Master's of Public Health training as well. I'm just going to put up something in the chat. I looked at this today again. This is Toronto Public Health data. If you scroll down to the second box, it shows the COVID prevalence in racialized communities. A month or two ago, throughout the pandemic, Black Canadians were at 2 times the risk of hospitalization as well as prevalence in terms of COVID. So, I mean, certainly we talked a lot about, I come from a clinical as well as public health perspective, and just really sort of infusing a lot of the conversation that we've had today into, really the more, the considerations around, certainly the data is telling me that it's definitely the social determinants of health, right? That we're seeing that's causing the inequities, crowded housing, not having days off work, finding daycare for kids, etc. So, I mean, I think our discussion has been pretty robust, and I think a lot of the emphasis has been on budgeting and operational efficiencies, which is super important. I think it, certainly we want to run a very robust organization with increased social determinants of health impact, which I have excessive interest in. But I think there's also building that value proposition at the patient level, and I think the reason why I threw that data in there is that we do want to, in the end, we're serving the needs of the community, and to building data will be helpful. I know it's hard in BC; it's nearly impossible, but also to, I think, in terms of just on the ground sort of efficiencies, meaning, I have a Syrian refugee. I'm just gonna, because I'm a doctor, I have to give a case. Just be very quick, okay? Syrian refugee, WCB case, doesn't speak English, gets run around by, WCB, doesn't understand the whole WCB rights and being able to navigate the WC system, live in poor housing. And then I, as a physician, have to navigate all that. I'd love to do that, but I know the fee-for-service doctors are not going to be doing that, right? And I think the whole, so that's why I'm trying to make it more tangible, is that what I see with the global funding is that it streamlines the process for me to work better with my social workers and nonprofits or community resource centers, so that we can have a shared community plan for this patient, perhaps share electronic social records. So I think developing language around that would be helpful for any proposal to the ministry. I know that may not be something they want to look at, but I think it's important to look at that, because in the end, it is about the health of the community, and a lot of my time is wasted in really piecemealing this patient's WCB journey, and frankly, most of them fall off the cliff. Literally, they can't work, and it's just a tragedy for 50 to 70% of these refugees who were engineers back in Syria, because we haven't done our job to integrate, like a shared community plan for these patients. And I really think, on a very visceral and granular level, if we do this global funding, it's great for our organization. We got operational and budgeting done, but really in the end, it's for that patient. And really in the end, I want to see that data, kind of equilibrate, if you will, and even be more, improved for marginalized patients, right? So.
Thank you so much, Jiwei. I appreciate both the reference to the data, but also the reminder that the reason we do this is because the health of real people. And that's what it's about. I've got John Calvert next, and then Barbara Wood, and then Daniel Cook. Thank you. John. You're muted, John.
Okay. Can you hear me now? It says, okay. First, thank you to the panel for an excellent set of presentations, which I found very insightful. And I have a few comments. A question that arises, I think, that all of us need to think about is why we don't have more community health centers in BC. And I think there's a variety of reasons. One is, of course, I think most people have no idea what community health centers are about. They don't have any sense of this option being feasible. They don't have illustrations. They don't have places where they can go and see how a community health center works. Really, REACH is the only one in the province that has the wide scope of different services. And as was noted, REACH faces a lot of barriers in terms of getting the kind of funding that would make it able to do really a much better job than it currently has. So that's one thing. So there's a job there in terms of just spreading the word, really. A second issue, I think, is we have to acknowledge that the doctors of BC have not been supportive of this model. They have a particular view of how physicians should be paid, and that's the fee-for-service system, piecework, if you like. And they're very dug in to keep that model. So they are not interested in physicians on salary, and not interested in physicians who are required to, in some way, be accountable to communities for the work that they do. So they have dug their heels in. And it's not as if the province is not aware of this model, or that there hasn't been some work done over the last 3 or 4 years. The province did have a process to investigate CHCs about 3 years ago, and some of the civil servants who were involved in that clearly understood what CHCs looked like. And then it all sort of fizzled away. And I can't help but thinking that that was because there was a lot of opposition from the physicians. What's different from Ontario is, of course, when you've got 105 CHCs, you've got a critical mass. You've got a lot of people who see how CHCs work, or who are members of CHCs, who've got friends and family who are participating in CHCs. And as a consequence, as we're a lobby group, or as a set of organizations that can advance the benefits of CHCs, they're in a much stronger position, obviously. And despite different changes in government in Ontario, CHCs have managed to flourish there. And I think they provide care and other social services to something like 7 or 8% of the population right now. So they're a very, very well established part of the system in Ontario. So I guess the last point is just to reinforce the view that what REACH does is not simply biomedical, although that's important, of course, but the social determinants of health are absolutely critical to improving population health. And if you don't have organizations like REACH doing that, then we're going to have all sorts of other problems, which are costly to deal with, because we're not dealing with things at the root, at the upstream level. We're dealing with people who, after they have had unfortunate either health or other experiences, are then thrown into the medical system to be treated, as opposed to preventing that in the first place. So I commend the panel and the REACH organizers for doing this, and I hope we can spread the word much more widely. So thank you.
Thank you very much, John. I particularly appreciate your focus on how we can spread the word, because in the end, it's going to be the voice of the community in an organized fashion around the province that actually brings about change here. So I appreciate your perspective. We got Barbara, we got Daniel, and then we've got Colleen, and we have about 10 minutes left in this section. Thank you very much, Barbara.
Thanks also to the panelists for this. It's just really important for us to dig into it and look to see how we can move forward. My question's really brief. I'm just looking at what are the obstacles that have been identified. John's just identified a couple of them. I think lack of knowledge. So there's, public support is low because people don't know what we're talking about or what's possible. Doctors of BC might be another one. I'm not sure what other obstacles exist. I think for me, that would be helpful. Also what Jiwei was saying, just in terms of having the data and the sort of the science to back up what we're saying. I mean, we think it's obvious in every explanation and every situation we see, it seems obvious, but to have that data also would help us. So I guess I was looking through what obstacles we've identified and how we can address them. And that's maybe a broader question, but that's what I was thinking about.
Thank you very much, Barbara. Daniel, and then Colleen. Daniel.
Thank you. Hello, everybody. My question is about, I think I heard that global funding offers a lot of flexibility for offering programs, but also I was making dinner, so I may have not have heard everything that was said in the panel. So my question might have been already answered, but so say there's a program that is operating in like the downtown east side, and it's working with youth, very marginalized youth, and their program all of a sudden lost its funding, but they're doing awesome work, and they reach out to the community asking for help, and REACH has the ability sort of to help, but because of the funding and because of procedural restraints, it couldn't currently, and we just had to watch the program die. With global funding, will it offer more flexibility in supporting programs in an emergency like that?
Colleen, thank you, Daniel. You're referring to the hip hop drop, I believe, that was functioning for a while. Colleen, you're next in line. Do you want to respond to that as well? You're muted right now.
Sorry, I wonder if Nicole would like to respond to that.
Well, I can respond. I think it all depends of the programs. It all depends. Like we're not financing programs. We may want to provide support in terms of resources. It all depends, right? Like we could now finance, depending if we have the money for it, just because of our our dental and pharmacy. But that's not what we are for, to finance other programs. That's we can support, but that's, yeah, I think I'm gonna stop here.
Thank you very much, Nicole. Okay, so I've got Colleen next in line, and I'm noticing we've got about 7 minutes left in the conversation before we wrap up the evening. So what I might do is invite Colleen to respond to the comments, and then offer Stacy and Nicole a chance to respond as well. And then we might sum it up if that's okay with everybody. So I'll start with you, Colleen, then I'll go to Stacy, then I'll go to Nicole.
Great, thanks. I was going to respond to a couple of comments that have been made. One was by Jiwei about evidence. I think that's really important. And in fact, the BC Ministry of Health commissioned a report from McMaster University to look to provide information to the ministry about how community health centers function in the province of Ontario. And this report was just submitted in 2020, so it's not even that old. And in spite of the growing evidence in Ontario that supports the use of community health centers for not just for complex patients, but as venues where people with complex health problems do much better than they would in another type of venue. So in a solo practice or group practices, some practices that have different funding models like fee-for-service and capitation mixed, the globally funded community health centers really provided the strongest health outcomes for patients that are considered to be complex. And the way that they measure those health outcomes, from my perspective, is a bit crude because they're all medical endpoints. So how many times do you go into the emergency department, et cetera? It wouldn't take into consideration some of the points that were raised importantly by Stacy about decreasing the use of other types of services in the community, like policing and so forth. So we need better measures, I think. There's no doubt about that, but I think that there is mounting evidence. And as I mentioned earlier, the US, which really does this well, is piloting global funding for primary health care. And so they do target their services on not only people with complex health conditions, but also people who are on the lowest steps on the income ladder. So, but it will provide us with important information. And I'll wait for my concluding comments later.
Thank you very much, Stacy.
I think that the thing to be mindful of when you're trying to get these ideas through government is one of the terms that has been used in the States to talk about the value of a crisis care continuum or any kind of health or social services model where you do the easiest stuff before you invoke the harder stuff is the concept of least restrictive, least costly. So the more you can move people to, the more you can provide a right-sized response. That's another term that I've heard a lot of, is the more you can the cheaper you can, the more efficiently you can provide services, and the less disruptive it is for the people that you're working with. What you're really doing when you're providing that kind of service is you are trying to maximize people's control over their own health and social service outcomes by really having the lightest touch that you can have and still be effective. And you can rely on, well, if a harder touch is needed, that person will cycle back in. But you'll find that people don't cycle back in as much as if you way overdo it, right? So any person who ends up taken to the hospital by police now has, is less likely to reach out for help and is more likely to be in severe need when they finally do get help. So that is just going to create much more use of the most expensive pieces of the healthcare and social services model that we have, and less of the low touch. I mean, we literally we can't do less than answer the phone, right? Like, we are the cheapest thing you can possibly imagine, aside from the Health BC website, which is marginally better than Google. So really, like, focus your funding there, and then you're going to see that the rest of the services have less to do, and that's what you want.
Thank you so much, Stacy. Very eloquently said. Nicole.
Okay, yeah, that's difficult to follow that one. I do agree that developing the language around value added is extremely, extremely important, and also the value proposition to the clients. That's what, in anything we're doing, that's what the ministry would want to hear. I think it's important to develop like a shared community plan for the patients. I think to work in partnership, all these languages I think are important if we want to develop something around global funding. I still think that, and I want to say it, it's like, it's not necessarily that I want lots more money that Reach has at the moment. I just want to decrease the inefficiency. I report to 19 different funders per month, per week, per year. This is taking 20% of my time, 20% of my manager's time. So if everybody can put their head together to have like the language around it and the value added to the patients, I'm in. I can sign in.
Thank you so much, Nicole. Yeah. I'm going to ask Colleen to sum things up here in a second, but I just want to remind people we're going to put in the chat the Gmail, or pardon me, email address that you can contact Reach at, because we hope this is the start of a process here, and we would like to invite each and every one of you to work with us and stay tuned for what the next thing that we're going to be doing is. It's info@reachcenter.bc.ca, and we will keep you posted. And so before I give my final closing remarks, I'm going to pass it to Colleen to sort of sum up the evening. Thank you, Colleen.
Thanks. Thank you, everybody, so much. This has really got my mind now going, and I always like to think really big. So the three points, not the only three, but 3 points that came through quite strongly in the discussion was and this is something that certainly Reach has been grappling with for several years. How do you describe to the community how and why they would benefit from global funding without saying global funding, but using something else? And so I think that really is an ongoing challenge. We do have to figure out what the right language is, and we have to speak to people as patients, but we also have to speak to them as members of our community, and not just as somebody who has a relationship with a doctor, but somebody who has a relationship, as Bill said, with our community health center, and that's our broader community. So communication is really, really important. The second point that was made by a couple of people, John Calvert said, spread the word, and Audrey was talking about organizing. And so both of those things are really important. We have to figure out some way to bring people to a common table, to begin sharing our experiences with the type of funding that we receive, and so that we begin to understand each other's challenges a lot better. And then we have to develop an organizing strategy. And that leads to the third thing, which is a political strategy with this government. We have to, BCATCH is engaged in an ongoing discussion, which is very, very slowly moving along. If you're waiting for that to happen before the icebergs melt, you probably are on the right track. So we have to figure out our communication strategy, our political strategy with this government, and our organizing strategy. And so I'm hoping that one of the things that that we all will do is sort of think about that. And maybe the next step is to basically set up a kind of a structure for these discussions to start happening. And that would be somebody convening a meeting, a round table. Hopefully it's going to be face-to-face at some point, not too far down the road, and then move forward from there.
That's great, Colleen. Thank you very much. And I also would just like to highlight that the time's going to be coming soon when people are going to reflect back on how did we respond to COVID, because we're getting sort of near the end. And I think it's reasonable from the evidence we've heard from the panel tonight that one of the best lessons of how we responded to COVID might be that global funding allowed us through the back door to in fact respond more effectively, quickly, and precisely in a way that helped people face crazy, unexpected, huge disasters in their lives. And so maybe if we took the advantage of that timeliness, then maybe the roundtable might be able to focus on that. So what I'd like to do now is to thank Colleen Fuller, Stacy, Ashton, Nicole, LeMire, and Shari La Liberté at VCC, and Sunyun and Suzanne and Catherine, our VCC team, all of the people who came out to listen and to ask questions tonight, all of the people who work at REACH on an ongoing basis on behalf of all of us to help keep community health in community hands. And to you, thank you again. And we will let you know when the next one of these things is going to happen. And we hope to see you there for that. So stay well.
Thanks, everybody.
Bye, take care.